Morning, Neil. How are you?
Yeah, good, thank you, Kevin. We're here in San Donato. I'll just say a big thing about the team here. They're doing a terrific job. And at long last, Lucien and I are getting to do a case together. So we'll go straight on with the clinical details.
Our patient is female, 5 years old, body weight 16 kilogram with height 110 centimeter, part of the twins, born at 32 weeks. Since birth, diagnosed with patent ductus arteriosus, normal growth. Physical examination, he had continuous murmur at the left upper sternal border. By the ECG sinus rhythm, normal AV conduction. Next. This is the chest X-ray. As we can see, the cardiomegaly. Next. In the echocardiography, we have seen the BDA 3-4 millimeter with high velocity left to right shunt and the enlargement of the left ventricle. Good systolic function. Next. Next. Thank you very much.
Okay, good. So I think you got that. It's a fairly straightforward, fairly typical duct. Maybe slightly interesting that the little girl had been a bit preterm, although 34 weeks isn't so bad. Although Lucia and I was 34 weeks premature. Did you know that?
Yes.
Okay, so we'll show you the angios now. The hemodynamics, PA pressure is normal. And Kevin, just reassure me you can see the lateral angiogram.
Yeah, no, we're seeing the lateral at the moment.
Okay.
It could do with a little more dye, I think, or different profiling.
Yeah, well, we'll show you a different profile. Let's go to RAO. It's a slightly tortuous duct, so I think no one plane will get it. Let's go to the RAO, please. There you are. It's got a nice ampulla. And you might have a bit of a discussion as to what you're going to suggest we use. Lucien's already made up her mind, and I'm not going to argue with a woman in the cath lab. But you tell us what you think.
Well, I would have thought you probably really didn't even need to go in the vein here. That you could have just closed this with your favorite device, the Amplatzer ductus occluder 2, the non-additional sizes one with a simple 4 French arterial puncture.
Yeah, that's a good suggestion. Other than the fact that it's my favorite device, it certainly isn't my favorite device.
That I know.
And actually, I wouldn't use it here. ADO2AS would have been a reasonable choice. And you're right, we could have done this from the aorta, but we did it in a more conventional way. Any other comments?
No, I suppose the ordinary Amplatzer ductus occluder 1 will do a very good job here.
What do you think, Lucien? What size?
Okay.
She wants to use it. Okay, and the size? What size do you want? That's a 2.93 millimeter duct.
3.9. So you're going to go with an 8.6?
2.9. 2.9.
2.9. Okay, so I think a 6.4 then would probably be okay.
Okay, good. Well, we've already chosen our device. It's very similar to the 6.4. Okay, good. And shall we load it? It's rather quiet there. Have everybody gone home? Are they not back from the coffee?
We're just. I'm not clear. What device are you using, Neil?
Well, it's the one that's very close to the 6.4.
Oh, 5.4.
That's the one. Now, I was hoping Lucien would load this. Well, let's go close, please. Lucien's going to load it because she's younger and has good eyes. Let's go really close, please.
So Neil, is that a
Closer,
6
closer.
French torque view that you have in the?
Yeah, it's a 6 French torque view with a 180 curve.
Yeah.
I don't think I do anything particularly strange compared with others. I like to have the sheath well down in the descending aorta and deliver the device, deliver the aortic side of the device and then bring it back. How are you doing? I'm just going to check that in the aviation way. Listen, that's beautiful. I don't suppose we're not. Milan is usually the best at close-up TV. Anyway, I think pretty much everybody's familiar.
Yeah, no, we can see it well. I mean, would you always back off the screw at sort of a quarter turn or something?
Yeah, definitely. And Lucienne had already done that. Obviously well trained.
So you have implicit trust in her.
Implicit trust, but I did check. But I check whoever's done it, whether it's, and if I've done it myself, I get somebody else to check it too. It's the aviation way. Okay, so I'm not sure. You probably would do better looking at the fluoroscopy screen.
But we're seeing you very well.
Yes, well, as you know, my mother used to say I had a great face for the radio. Is to bring the pigtail back. So here we are. The only thing you've got to have your wits about you with this sheath is that the marker band is actually just a couple of millimeters proximal. And you think your device is actually out of the sheath, but it's not, of course. I'm trying to give Lucienne the opportunity to deliver the device, but she's refusing. Okay. I'd like to bring that. I don't know whether people have a comment about it scraping the aorta. I'd rather do that than deliver it just.
It seems harmless. It seems harmless, doesn't it? That that scrape of the back wall of the aorta.
Yeah. Well, I'd rather that than bring the sheath back directly adjacent to the duct and risk the risk of abutting onto the lateral wall of aorta. So I've got a bit of tension here. And just backing this off now.
So Neil, I noticed that you don't bring your pigtail back like we saw yesterday and do check angios during deployment.
Well, I'm going to check now. I'm not sure I like that, actually. Okay, let's check then. Let's have... Let's go. That's okay. Lucien's being a bit mean on the contrast, but we're trying to save money. I think I'd feel happier if we did that again, Lucien. Okay, let's go. How much are you giving us? Yeah, 12? 12 at 10? Yeah, okay, good. Let's go. Okay, well, I think we're confident now.
Pretty perfect.
Right, Lucien. Lucien's going to release the device. Your Honor, I begged her not to release it. I take it you're happy with all that, everybody?
Yeah, I mean, it looks, complete and instant occlusion.
Okay. Very nice. And we will repeat the angiogram because it's the sort of thing I do. And let's bring the sheath out of the right ventricle, Lucien, please. Bring it right back to inferior vena cava. Okay, good. I think we're ready.
It's okay.
Tiny bit of smoke there. But I think we got the right size.
Yeah, but the smoke is nice because it shows the pulmonary end.
Yep. And we'll just go RAO, please. 30 RAO. Kevin, I'm conscious. Who's the next speaker? Is it Dr. Ormerod?
It is. It's Oliver. Yes.
Far be it from me to stand in his way. Okay, we'll just do this RAO angiogram and then we're done.
No, I think we're doing fine, and he's ready and waiting anyway.
Beautiful. Okay, good. It's sitting nicely in the ampulla.
Okay.
So I'll just
Very
say,
well done.
I'll just say thanks again to the San Donato staff. They're doing a terrific job. Great to do this in.
And very well done. Beautifully executed case.
Thank you.